My name is Jamile Shammo. I'm professor of medicine and director of bone marrow failure at Northwestern University. Welcome to the MDS roundtable discussion. Today, I have three expert physicians that are joining us to talk about MDS. And so I'm going to turn it over to them so that they can introduce themselves. Dr. Swoboda, you want to start?
Sure. Thank you so much. My name is David Swoboda. I'm the director of leukemia at TGH Cancer Institute in Tampa, Florida. And I'm really excited to be a part of this panel.
Dr. Sadeghi?
Hi, I'm Saeed Sadeghi. I'm clinical professor of medicine at David Geffen School of Medicine at UCLA, and thank you for having me.
And Dr. Benton?
My name is Chris Benton. I am a hematologist and leukemia doc at Rocky Mountain Cancer Centers, which is the U.S. oncology practice, and Sarah Cannon research practice in Denver, Colorado. Thanks for having me.
Of course, welcome. And so it's kind of interesting to meet up again and talk about all the changes that have occurred in the last year, perhaps, in MDS in general, not only in terms of the revision to the diagnostic criteria. Now we have two separate sets of diagnostic criteria, WHO and the ICC, but also in some of the novel treatment options that have emerged for the treatment of this disease, mainly in the lower risk grouping, if you will. So I'm going to start by asking you, what do you think has been the most impactful in that regard?
Sure, I can go ahead and start. Yep,
Yeah,
I'll go ahead and start. Yeah, so, like you said, we have had a lot of changes since 2022 with the ICC and WHO classification. I think really with the way that we think about diagnostics and prognostication of MDS, that has changed a lot. Now really focused a lot more on the molecular makeup of MDS and less on just solely on morphologic makeup of the disease. So with the ICC classification, now we think about MDS really as a spectrum between MDS and AML, especially in patients with elevated blasts. And we also have certain disease subsets that are now defined by their molecular mutation, with SF3B1 and TP53 being two that I can kind of mention. And then thinking about prognosis, we previously had just had a combination of cytogenetics, blood counts, and leukemia cells that really helped form our IPSS-R, which was our prognostic scoring system. But more recently, Elsa Bernard and others, looked at and really defined a prognostic scoring system based on the molecular makeup of the disease and really added that in. And now we have 6 categories of MDS based on this, what we now call IPSSM. And I really think that has started to translate into our clinic and in our clinical practice on how we manage our patients. But I'll turn over to talking more about therapy to the other providers.
Yeah, so I agree with everything that was said. And I think where this kind of molecular stratification and molecular characterization of MDS has led us is to think about how we treat different types of MDS. Firstly, how we approach lower risk MDS, and sort of, are we reaching a point where we can use disease modifying drugs in lower risk MDS? And also what treatments to use. So for example, some mutations that we can target, we're already using therapies for instance, in IDH, mutated MDS, even in FLT3, JAK2 mutated disease, CSF3R is another potentially targetable mutation, maybe even RUNX1 in the near future. So we have a lot of information from these molecular mutations and the additional information that we gather from the marrows that can stratify MDS, but also this in these kind of 6 categories in IPSSM that was mentioned. This is something that definitely I think will help to clarify our treatment strategies.
Yeah, and actually the only other thing that I would add in this is that when you look at IPSS-M now, the molecular classification, and you compare it to IPSS-R, studies have shown that, they don't exactly directly correlate, and actually you can have either upstaging of patients, maybe in about a quarter of patients, or downstaging of patients. So I think it really speaks to moving forward and incorporating the molecular prognostication for these patients, because we potentially can identify patients much more accurately in terms of the therapeutics that we're going to use for them.
Yeah, and it seems to be, I completely agree. We seem to be moving into more of a molecular targeted phase of MDS as opposed to just morphological abnormalities that could be seen under the microscope. Knowing that more than 2/3 of patients who have MDS have lower risk disease in either classification schema or risk stratification schema you look at, what do you think is the most important need in the management of low risk MDS patients at this point?
Well, I mean, I think that for patients with low-risk MDS, really the paradigm and the important thing is to actually improve their quality of life, improve their hemoglobin levels, improve their, or reduce their need of transfusion. I mean, ultimately that is what our goal is. Now, down the line, obviously, there is potentially for this goal of also improving the survival of patients as well. And I think that would be something that hopefully we can show in the future. But definitely with the new therapies that have been approved and now are coming to the forefront, we are getting this significant improvement in the patient's hemoglobin levels, as well as reducing their transfusion needs.
Yeah, no, I definitely agree. I think the needs have come up with now actually being able to utilize some of these drugs in our clinical practice. So, in ASCO, 2 years ago now, the COMMAND study was presented, the IMerge study was presented, ultimately both leading to FDA approvals of luspatercept in the frontline setting when it was a randomized trial versus ESAs, and imetelstat being approved in the post-ESA setting. And so, we've now had luspatercept available in the relapse setting, but now in the frontline setting for a period of time. I think as we use it, just more and more questions, unmet needs, arise. Can we start to think about more combination therapies? What patients are the right patients to use luspatercept or not? And so we're starting to learn a lot more as we utilize this drug. With imetelstat, it's just really coming into clinic in the last couple of months. I think we still are sort of figuring things out and still really early outside of the clinical trials and how to utilize that in real life practice. But importantly, that I think that drug can be very helpful for our patients, and will be interesting to see how the utilization changes over time.
Yeah, I couldn't agree more with what's been said, both in establishing disease-modifying therapy and also, improvements and sort of clarification in how to sequence and combine therapies. One thing I've noticed in my practice is that some patients seem to have an improvement in functional status with an improvement in the hemoglobin, other patients less so. I think that, sort of studying that correlation between anemia responses and improved functional status is important. And especially for patients where we're able to achieve transfusion independence and improve their anemia, achieving longer lasting anemia responses. As it stands now, patients oftentimes eventually, even if it's months or years down the line, lose their response to these drugs. And so, one of the needs, I think, is to extend these responses and ultimately, even help reverse the course of the disease.